name is Kim Blackwell, and I'm the Artistic Director at Fourth Line Theatre, and I'm thrilled that you're joining us today. I'm so excited to have a conversation with this amazing human being, Dr. Jenny Ingram, and I guess I'm going to start right away. I'm going to ask you, why did you decide, or how did you come to the idea of doing a film that you've never done a film before at this point in your life?
The COVID pandemic was very difficult for me to watch. I spent some time educating myself on what Canada has done. I read a particular Aging Well report, which was done by Don Drummond, and it characterized where we stood in Canada as being not up to snuff when it came to the seniors arriving on the horizon.
And there's a huge bubble of you coming,
Yes,
right? I think are you part of that baby boomer?
I'm at the front end of the baby boomers.
And baby boomers are 46 to 66, 1946 to 1966, is that right?
Yes.
Technically?
Although I'm not 1946, I just want to make that clear.
I'm not saying I'm 1966 when I'm a Gen X,
Yes.
right?
I became very discouraged.
My mom and dad were locked down at Rubidge from March 8th. I never hugged my mom again until she died on the 27th of September 2020. And so she had Lewy body dementia. I've mentioned that to you before. And that isolation, I heard so many people passed away from dementia during COVID.
It's terrible. And I don't think the general public realized how much the institutions that we have, that we rely on, also rely on families to fill in all the gaps. And so people who normally would be up and dressed and moving about the facility,
having kids come to visit,
without their families to make that happen, they were left adrift, and many of them just remained in bed.
And mom and dad at least were together, but they ate off styrofoam, I think, for 8 months in their room. I can't even imagine if you were single.
And you think back to what it was like in sort of a circumstance in your life where you were not allowed out of a room. It just feels like prison, and I'm sure it was a terrible time. I could see how that bubble of the population was going to walk through this area, and I've always heard that we would make changes to how seniors were managed, the way we had made changes to public schools and unemployment insurance and old age pensions and maternity benefits and colleges and universities, everything, every step of the way that baby boomers walk through their lives, the population changed how governments managed money. And here we were arriving at old age, and nobody was noticing and nobody was doing anything.
And you said that there were reports coming out as early as the mid-1980s warning of what's about to happen, which is your number that is in the movie is the number of people with dementia is going to increase by 187% by 2050.
That's Canada-wide. It's higher than that in Ontario. It's over 200% in Ontario. So it's going to triple within our community easily, and we're already an older community. So after the pandemic, I began to question what I could do to make a difference. And I decided that the governments had to hear from people. How do you mobilize people? You have to first help everybody understand the problem. And I can't tell you what my patients go through, but they could tell you what they go through to try to remain at home. And that's the big difference between Canada and other countries that have done this better. Countries in the Scandinavian areas have started in the 80s and said, we're going to help people stay at home. Not that they don't have long-term care institutions. They do. Not that they don't have places for people to live in senior-friendly housing, but they said we're going to help people stay at home.
And it seemed like what you were describing to me last night after we screened the documentary was there's more of a list of choices of what people have more self-determinism on how they want to be supported. Would that be right to say?
Exactly. They adopted a quite different philosophy from the one we use here in our home care services. They go and ask people at the age of 80, even if they're healthy, what can we do to help you stay at home? But if you develop a dementia or Parkinson's disease or ALS at a younger age, then you are initiated within that system at a younger age.
Oh, so it's not just like 80 is a hard line in the sand, so someone with an early onset can access it.
An early onset dementia would begin to have visits every 6 months, and they would say, what can we do? And the list of opportunities or issues that they're willing to address is extensive, and you basically, kind of like a shopping list, pick off the ones that you and your husband or you and your kids or you alone feel would make life work better for you. And in contrast, in Canada and in Ontario in particular, people who have dementia have a person arrive only after the doctor makes notice to them, and the coordinator comes, and what the coordinator has to do is complete a big, extensive form, add up a number of points that determines what they are allowed to offer you. So it's kind of like Big Brother tells you what they're willing to give you based on a point system that is accrued supposedly from understanding your situation. But basically what it ends up being is that they offer you help that is physical help with a bed, with a bath, or getting dressed. And if you don't want a bath and you don't want to have someone help you get dressed, it's a situation where there's very little else. And so it's intrusive and it's offensive and it's...
But it also feels like it's getting it wrong and spending a lot of money getting it wrong.
It spends a hell of a lot of money getting it wrong. Very high-paid nursing staff who are excellent. I don't want to say the individuals are in any way improperly administering the tests or improperly interacting. This is how they've been trained to offer service. And truthfully, it's just a system that is not designed to make it easy for the person who's receiving the help.
And their families,
help.
right?
And their families.
And you certainly focused in the film on families. So I am so curious. You had this idea in COVID to do some sort of a call to action. You referred to it as you sort of being the canary in the coal mine. Your body of work, your lifetime work, a lot of it is around geriatrics and now geriatrics and dementia. How did you film such a beautiful film? Did you know how to film a film? I mean, I wouldn't know today if I decided to do a film on something. I wouldn't know how necessarily to do it.
Well, I have to, first of all, thank you very much for your kind words about the quality of the film, because in many of my screenings, people are caught up in the messaging and caught up in the cause. And not many people have noticed how beautiful the film is. And it was really nice to hear that you thought it was beautiful.
Well, you shot the Lockington Cottage from above with the trees changing in Ontario. It was stunning, and many more things besides
So
that.
we had just a wonderful crew of both videographers and editors and voiceover people.
Megan Murphy,
and
Megan
they're all
Murphy.
local, yes. Yeah. I think they did a marvelous job. And until you see the raw footage, you don't know how you're going to put it together. Yeah. So Pavel did the videography, and then Rob Viscardis did much of the editing to pull the themes together. Did you sit with
Rob in the editing room?
Rob and I sat together for hours. Now, he would generate a way he thought it could run together, and then we would massage it and massage it and massage it. And he was brilliant in how he wove, in my estimation, how he wove the story of the Gordoniers from the beginning right through, right to the end of the
Bill and Diane were
document.
sort of everyone was important in it, but Bill and Diane Gordonier seemed to be the connective tissue in the piece.
They were the only family who was in the throes of trying to obtain home care during the time of filming. And it's very difficult, if you think back with your family member, when you're in the middle of it all, to have someone then come in and say, would you help us by allowing us to videotape how you do things around the household? It's not an easy ask.
Well, I wanted to ask about this. So Diane was sort of in the throes of dementia.
Yes.
Very angry. There's a really difficult scene around that, some
Yes.
physical violence. What was her response to having the camera crew in the house?
Well, I think in most situations it was managed very well, because when I was interviewing, we had two interviewers, by the way. When I was interviewing Bill, I brought a nursing friend with a lot of experience in dementia who took Diane for walks and took her to the basement to play cards and to look at her picture books and her family photos in what I feel was a very appropriate way. I think some of the irritation that Diane expressed was contingent on the environment of that particular morning, and the videographer went in on his own quietly to kind of get the waking up of the household on videotape. And it was in that day when it was really no questions being asked. It was just an observational day. There was no third party other than the fellow with the video camera kind of perched quietly in the corner. So I think we handled the videography part as well as we could. One of the other interviewers was Karen Wells, who's a well-known
from CBC.
Yes,
Yeah, we love Karen
She's
Wells.
a well-known
Yes, she
CBC
is.
documentary producer.
Big fan of Fourth Line.
And she is an author.
Oh, she's amazing.
I know. And she's been on the planning committee, and after seeing the first several cuts that we had done with me doing the interviewing, she asked if she could help and do some of the interviewing. And it was in fact Karen who asked, I assume, the tough questions that caused the answers that became very much the poignant end to the film. And she did about half of the interviewing. I did about half.
Oh, that's exciting.
Yeah,
It's
no, it was a
amazing.
wonderful learning experience.
What was it like for you to see it? It was at Reframe. Was that the world premiere of it at Reframe?
Reframe was the premiere of the film. We had had one prior showing for the families to allow them, because they had never seen it from the time we did the videotape with them up in the Huntsville area, down around their homes. They had not seen it put together, and I thought I owed it to them to have a quiet time to kind of reminisce and kind of take down the temperature if it needed to be, if it was terribly difficult. And I know that at least one or two of the family members wept through the showing for families, and so I was glad we did that. At any rate, since then, I've left it open to anybody on screen if they want to come to film showings where there's a Q&A at the end, please do so. And they keep on coming. 3 came last night, plus the dog Arlo. And it isn't uncommon for me to have 5 or 6 of the people who are on screen arrive at these film viewings. And I think that's important because often, although the messaging of the film begs the question, what do you want done to the healthcare system to support people with dementia? The real sort of heartfelt exposure that intimate glimpse into how decisions are made, how your mom with dementia can be present at your wedding, even though they're advanced in their dementia, how girlfriends can kind of problem solve around getting you off, wanting to go home and be picked up in the middle of the woods by your husband where there's no road. Those kinds of things are learnings that the general population has to understand, and they love having people with the experience behind them that they can sort of ask those tough questions and say, how did you do it?
Yeah.
So it's a two-pronged educational event taking this movie across Ontario.
It's so amazing what you're doing, and I know you're putting it into film festivals. I'm curious just about sort of you and your career. Now, did you do your medical degree at Queen's?
Yeah.
And you're an internal medal. You were an internalist, right? Is
Yeah,
that what you
internal
started with?
medicine. So internal medicine is the basic training people do before they are a cardiologist or a rheumatologist or a whatever you tend to go into. And geriatric medicine was just being born as a specialty when I graduated out of internal medicine. So I did my undergraduate. I started actually at U of T and moved to Queen's, and then did my specializing in internal medicine at London, at University of Western Ontario. And I had done most of my training in those years in the geriatrics department because it fascinated me. I always found it difficult to know so much, shall I say, neurologists seem to know, can pinpoint something inside the brain in some specific spot. And I always thought that was irrelevant. I wanted to know about the whole person and the person's family and the person's background and their job and what made them tick. And geriatric medicine just was an answer to a prayer. It was only just developing as a subspecialty, but it was just perfect for me.
So you were in your 20s.
Yeah.
It wasn't like you grew into geriatrics out of internal medicine.
No.
You kind of came out of the gate.
Well, it was holistic. And I come from a background where, my family members were unique people within their professions who tended to approach their jobs in a very holistic way.
What is your connection to Vera Peters?
So Vera Peters is my mother.
That's what I thought.
And
she's a very famous cancer doctor.
she was a very famous cancer
Chain-smoking
physician.
cancer doctor, if the internet is to be believed.
Well, up until the end. But
Okay.
the issue of what she did, which was interesting, is that she recognized that the people referred to her, who were all the people who had breast cancer, who didn't qualify for the most usual treatment, the mastectomy, usually because they were too old, usually because they were too complex, had too many other conditions, and she treated them in a holistic fashion. She got rid of the lump and then gave them a little bit of radiation after if they needed it. And lo and behold, years later, she found out they were living very full lives. So in many ways, if you compare what she did and what I'm doing, I've often thought that there's a synergy there because, and this is something people don't realize about geriatrics, we have learned so much from managing conditions like breast cancer in people who are too old, too complex, have too many medical conditions. Right. And we found a better way, which now is a standard of care for everybody. And the same is with the insertion of heart valves through the groin. That was another advance that came because people were too old, too complex, had too many conditions to survive having their chest opened. And they developed this new procedure called a TAVI. And now it's a standard of care for many people to get a new aortic valve. So geriatrics is the birthplace of interventions and change that benefit people right across the healthcare system. And people don't realize that. And dementia is going to revolutionize how we deliver healthcare if we listen to the public saying, this just is not working.
And what I'm hearing you say, once again, you're pulling in that holistic ethos you have to looking at dementia. Would you agree?
Oh, absolutely. Absolutely. I mean, I've been told by the teams I work with that my approach, once I give the diagnosis of dementia, is quite different from many people's approach, because to me, the diagnosis of dementia is just the beginning of a long-term relationship that involves me and the patient who has the cognitive difficulties and that entire family. And we need to figure out how to make the life of the person with the dementia fulfilling. And we have to learn together what the skills are of the family that we can employ to make that life fulfilling.
Because it is a cognitive issue like dementia is different than a cancer or a COPD. Absolutely. Because there isn't pills to take to manage it right now, right?
Well, there are things that we do and there are medications, but that's the impact of the existing pills, if you will, has been modest at best. And it doesn't negate the fact that there's an issue day to day of a short-term memory problem, a word-finding problem, difficulty in accomplishing tasks, whether you're on the pills or not, that has to be dealt with.
Right.
And our systems of support are just so based in physically either doing it to you or doing it for you, that this idea of doing it with you is not part of the paradigm. And so we've developed this expensive system, this patriarchal system, this top-down system of we know in the government what you need and this is what we're going to offer. And we've missed the boat. And that has to change. Now, if it changed, it would benefit everybody in healthcare. It would benefit the hospitals.
Because the ripples would be amazing.
The ripples
right?
of this blind spot for political spending and this blind spot for policy is traumatic in all the places that people with dementia have to then turn to get those simple answers. Yeah. And they go to the Emerge and they go to the hospital.
So then
and
they're clogging up parts of the healthcare system.
Exactly. And they don't want to be there. But
and to your point, I think you said about, I've watched my mom with UTIs, right?
Yes.
And who knew that UTIs can affect cognitive ability so much until you're in the middle of something where it's like, my mom is not talking like she should be, or she's acting like a crazy person. And then a little bit of antibiotics and suddenly they're kind of back.
That's right. So this is delirium. And medical people know this, but the trouble is we aren't walking the walk with the families at the front line to be able to pick it up and to help the family understand this. And even if you tell people about delirium, it's different when you're in it, because you have to kind of step back and say, why is mom so angry now? Or why is mom so confused today? She wasn't like this 2 days ago.
Yeah.
And it's hard.
But forest for the trees kind of thing.
Exactly.
Right.
But the helper coming in can say, whoo, what's going
Snap
on?
you right
and
out of it,
they know something's different, and then they start the process of looking for what's happened. And we can stop people from getting to Emerge in full-blown sepsis by picking up that they changed on day one and get them a urine culture, antibiotics, and lo and behold, we avoid hospital. And in countries where they do this, the selling point, people always say, oh, it's so expensive what you're suggesting. But truthfully, what we're doing is more expensive. And I try to tell that to people, but they don't want to.
Well, look at wait times at PRHC. They're off the charts. And I'm sure so much of that is people coming from, they said, I don't know if it's true, but in in the TV show The Pit, they said that they get really busy at 7 a.m. because everyone goes to check on the older people in the long-term care facilities. And if they're at all in delirium or a little bit off, that's when the ambulances roll in.
So, and that's from long-term care. That's not from home.
Yeah.
But, if you look at countries where they have set up the opposite system to ours, where they start early, they nurture relationships in that home-based service kind of way. They let families be involved in decision-making about what care would make it easier. Those countries have, and I'm going to quote Denmark, and I'm quoting the Aging Well report, they have people who love their healthcare system. They think it's great. They have only about 2% of all their acute hospital beds sidelined with people who they don't know what to do with. They have to go home. They shouldn't be in acute care, but they have no place to go. 2%. Our hospitals vary between 15 and 30% of their hospital beds. That's like $1,400 a day minimum being spent in acute hospital care on these people for the want of $200 a day of care at home. And so the analysis, now I'm a doctor. I don't propose that I understand the economic depths of this problem, but that's where the Aging Well report is so important, because that's an economist looking at our care system saying, we're not doing a good job, Canada. We are an outlier.
And having a roadmap to how we could financially do it better,
Exactly.
as well as morally do it better.
I come at it from a clinical perspective. Clinically, this makes absolutely no sense. I come at it from a physician and a care provider's perspective. This system we have makes no sense when it comes to staying at home. But from an economist's point of view, it makes no sense either. Yeah. So it should be a no-brainer. Pardon the pun.
Well, and I think that's why the film is a call to action in that way. We leave it going, and I want to talk about the Kawartha Center, and I think you have 7 calls to action, right now. I want to first, though, talk about GAIN, because that's where I first knew of you. So tell me what GAIN stands for and what it is and what you do/did there.
So GAIN is an acronym, and my husband reminds me every time I say the word GAIN that nobody knows what the GAIN stand for. So Geriatric Assessment and Intervention Network. Now, after you say the word GAIN, I always say a GAIN geriatric team, so that you get the idea that it's a team of people who have been hired and trained to do complex geriatric medical care in the assessment format. So they're trying to figure out what's going on in the very most complicated cases. And they try to set an intervention in place that will assist.
So are people coming to GAIN because someone or themselves have noticed some cognitive decline? Are you also getting people getting a baseline to then look at later? What are you guys doing?
GAIN geriatric teams, and there are 12 of them in this central east part of Ontario, which for me as a clinician saying, could I get a little help here in Peterborough because I'm alone in the oldest community in Canada? And the result were teams of professionals that were fully funded, long-term funding, 4 in Scarborough, 2 in Durham, and the rest in our area in Port Hope, Campbellford, 2 in Peterborough, 1 in Lindsay, and 1 in Halliburton. Fully funded teams. I mean, when they told me we had the first 4, I thought I had died and gone to heaven. When they gave us in this area 8 more, I just could not believe it. It was just a godsend, and it has been a remarkable change for our area. Through having GAIN, if we want to talk about the benefit to the community on a professional side, it attracted geriatric medicine specialists in droves. It was like, it was perfect. And so we went from having me alone here to having, I think we have 12 geriatricians in Scarborough, and we have 7 in Peterborough. We have more geriatricians in Central East than many provinces have as a result of the GAIN program. So I will say that it was not designed to do just, people who have early concerns about their memory, that sort of thing. And I can speak more about that. It was designed to help when you get to the phase of having so many complicated issues, heart disease, diabetes, a little bit of Parkinsonian features, too many meds, and you've now begun to fall, and oh, by the way, there's a little memory impairment, and my vision isn't very good, and I'm having trouble hearing. But other than that, I do well. I still go to Rotary every week. So it's that kind of a patient that it was designed for.
As we age, we get more complicated. Like I've always said, I had no drugs until I was in my 50s. And now I have a number of pill bottles. Soon I'm going to need blister packs. And then I'm going to need someone to deliver my drugs, right?
Exactly. So, age comes with its consequences. And the consequences imply we're going to take care of these things. And that implies that it gets a little more complex, and that's where geriatric medicine makes its mark. That we are the kings and queens of complexity, and that's what we love to do.
Because you have to look at whatever the physical and mental ailments might be, as well as all of the drugs they're on, and how they're counterindicated.
And by the way, the family and the money, and who in the family wants to get access to the money, and which neighbor is stealing the money. So we have legal, pharmaceutical, social work, sort of training and skills, capacity evaluations, and all sorts of skills that are not your average GP's skill set, nor should it be. And that's why the GAIN teams are so important. Wow. Now, having said that, we ran into a problem early on in that people couldn't get to us because if you're a doctor in this province, you need a referral. And people, if they didn't have a GP or you couldn't convince your GP that you had a problem, you didn't know what to do. So you go to Emerge and that sort of thing. Well, we decided that wasn't good for people to go to Emerge just because they wanted to see us. So we opened the referral system to the GAIN program so you can self-refer. Now, there aren't many specialist programs where you can self-refer.
I was going to say, I can't think of very
That
many.
was a landmark decision of ours, and the reason has proven to be very helpful. What happens if you self-refer is that we then get on the blower to your primary care physician, to your specialists, to your family, to whoever we need to see, and involve them in helping us to figure out what's going on here. If it's falls, it might be one answer. If it's the neighbor's son has removed furniture from the basement, then
you're
it's
literally
another.
dealing with it on all those levels in terms of what GAIN could be dealing with as intervention.
Absolutely. Wow. I mean, it's not everybody's cup of tea, but it was mine. So, and I must admit, I put my stamp on GAIN. For the people who are, I'm going to say, worried well or having concerns about their memory, GAIN is not where they should go. Oh, okay. So that opened up a whole other area of my career, which was to work with family doctors and family health teams and the Alzheimer's Society to try to figure out a way that everybody could get a decent evaluation of where their baseline cognition is at. And so that's why I started working around 2000, like 25, 26 years ago, training the nurse in the family physician's office to do a cognitive evaluation.
Okay.
And then word got out about this. I had about 30 different nurses trained all around our area, and it was really to try to fund that I went to the ministry to say, look, I think you should fund these nurses in some way so it's an ongoing thing. And they said no, and they set up a panel to say what they wanted to give us money for, and it ended up being the GAIN team. So it was a good ask. It just ended up in a different planet than what I started with. But I have always worked with primary care. Now, if you recognize that people are having trouble getting to specialists because there aren't enough specialists and there's a wait time and a lag, if you say a wait for 6 months to get your, let's say, your bunions fixed, that's okay. But when you've got dementia and you wait 6 months, I mean, all hell can break loose in 6 months if you don't get help. So with realizing that the waits were getting longer again, even with the GAIN teams, primary care doctors, GPs, nurse practitioners at the family practice level had to be part of the dementia care team in a big way. So when we studied it in about 2017, it became evident that the information I was giving the family doctors wasn't enough to allow them to make decisions for the people. They were still not getting the stories. So recently, about 4 years ago, we began working with one of our family health team members and a family health organization, one clinic, I better put it that way, the medical center. And the GPs and the nurse practitioners there allowed us to put in a better template of a team. We had help from the Alzheimer's Society and one nurse, and we had a clinic every week to see and get the stories, the holistic story, from the patient of the family doctor or the nurse practitioner. And then I trained them how to put it down on paper, and they had to learn how to collaborate, two people getting two different stories, because as you know, the person who has the dementia often has quite a different take on things than the family. And so this was a bit of a conundrum for professionals who haven't worked in a team environment. They don't know what to do with that. And of course,
because the patient is their patient, the family member is not, right? So
to a certain extent. I mean, after you enter the area of dementia care particularly, but senior care also, we have made it a rule that we don't see people without a care partner. Really? And that for dementia is an absolute requirement, because the individual with dementia, by definition, thinks they've done a whole lot more than they have. So it is not unusual, just to put a kind of a humorous take on this, to have a married couple there, one with dementia and a spouse, and the woman will say to me, "Oh yeah, I cooked a roast beef dinner last night," and the husband's just looking aghast, knowing that he has been trying to do the cooking for the last 3 years, and she's not entered the kitchen for the last year. Right. So if you don't get both those stories and then have some documentation of their cognitive status as well, you don't know what's going on without going in and watching. Well, we can't go in for everybody who we would like to go in for, although that would be great, but let's start where we are at. So we include both stories and we integrate it, and the results of my study was that given the right information, most family physicians are quite able to follow an algorithm of how to make the diagnosis and get to the right endpoint. They can make the diagnosis. They just have not ever been supported to have the right team asking the right questions in the right way to provide them with the right information. And once they've got the right information, they can make the diagnosis. This has to happen because if we only have teams to refer to, they will always, outside of the GP office, if you will, they will always have a backlog. Because the numbers are exploding. So we need all hands on deck. Sure. This is not a future that we can pick and choose who's going to be eligible to help us. Everybody has to help who's in the community.
Can you just define for me? So I always thought dementia was Alzheimer's, and they were the same thing. And until my mom got Lewy body dementia. And then I was like, oh, I guess there are different dementias. But can you just sort of define dementia and then talk about, a little bit about the different kinds of ways it presents?
So this is a sort of Dementia 101 part of every family conference. But dementia is an umbrella term. It's much like saying you have pain. It's a symptom. It's telling somebody that the person in front of you has got some brain challenges that are interfering with them doing their day-to-day activities that allow them to live independently on their own and get through life. And that it is usually progressive, and it's not usually something that suddenly arrives, and that there's no other reason for you to suspect they're doing it. So the fact that somebody is, drinking gallons of vodka, that's a brain problem that is a remedial problem.
Okay. But someone who knew how to get to the grocery store every day of their life and suddenly got lost.
Yeah. And that is evidence of the difficulty. And what we do is we try to eliminate the alcohol and the bad drugs, and we make sure that this is really a brain problem, not an alcohol problem or a drug problem. But when you get down to it, it is something that is happening in the brain. Then we look at the causes, and Alzheimer's disease is the most common. 60 to 80% of people who have dementia have Alzheimer's disease. That's why we talk about it as if it's the only or usual one. But there are many other types, and they all have their own signature that we as clinicians learn to recognize. And, last night when we had the viewing, there were people in the audience who talked about a family member who had a frontotemporal dementia. And those people often have either severe language difficulties that they can't express themselves, or they have severe behavioral problems. They speak very well. They know all their information, but they are bizarre in their behavior. I have great stories of
I'm sure
the little old.
My mom's Lewy body presented with her seeing little children and trying to feeling a lot of anxiety because she wanted to make sure they were safe.
Right. Lewy body dementia is different from Alzheimer's disease in that it presents often. It has some memory problems, but it also has features that look a bit like Parkinson's disease. Yeah. They tend to have a little bit of a shuffly gait, but it arrives about the same time as the dementia arrives and the memory problem arrives. And then if you get the hallucinations like your mother had, it sort of puts the icing on the cake. And because of the difference in their disease, they have a high tendency to have these very vivid hallucinations. And they're very different from the Alzheimer hallucinations. So Alzheimer patients will often say, oh, I think there was a man out there. And when you look out there, they can't really describe that man. And you see a tree that kind of looks like it could be a figure. And you figure they've kind of misinterpreted that tree. But they can't really tell you much about the person. Whereas when you have a Lewy body dementia, as you know, they aren't upsetting hallucinations.
No, Mom would
usually.
laugh. She'd see a little girl under the chair and laugh at her. And she said to me once, we were looking at a window on the third floor at PRHC, and she said, so just tell, you really can't see those kids tobogganing down that hill. And I said, I can't, Mom.
I know. And so mostly with Lewy body dementia, they are entertaining hallucinations. And we will have people describe for children, and they will describe what they're wearing, what cards they're playing, that their mother comes in and the cat jumps up on the table and the cards. I mean, it's detailed beyond belief. And
do we know what causes all of the different dementias? I mean, somebody said to me once about Lewy body, it's a protein buildup in the brain, but
I think for the purposes of this podcast, we might not want to go down this alley.
Okay, fair
but
enough.
I will say that we have the most evidence and the most clinically sort of relevant investigations on Alzheimer's disease, because that's where...
is it vascular? Is it like a...
No,
okay.
Alzheimer's is a protein buildup.
Oh, okay.
Of a protein. It's a protein that we all have in our body, but when your body tries to get rid of it in normal people, it does it one way. And if you have Alzheimer's disease, the mechanism to get rid of that protein is not working right, and it leaves behind protein segments that your body doesn't know should be garbage.
See, you just gave a very good layperson the description of something that I suspect probably is a 3-hour description.
Yeah, but it builds up that those proteins are different from everybody's protein in that they are toxic to brain cells. They kill off brain cells, and they don't just lie around as single proteins. They find each other and clump together, and then they make plaques and sort of do major damage. And they cause the cells that they're attacking to kind of involute and become all crinkly and produce other proteins that shouldn't be there. So the system is very delicate, and the proteins for Alzheimer's are well characterized. We can document those proteins in the brain with a PET scan. We can, which is just now clinically available. We give a radioactive material and it lights all the protein up. You can document it in the fluid around the brain by doing a needle in the back and getting the fluid off and analyzing it. That is not clinically available easily. And we're beginning to have a blood test that will document that you've got that protein in your brain, because they can find remnants of it in your blood. So that is not available through OHIP. But we're moving ahead in the Alzheimer's world quite quickly, quite dramatically, in both the analysis and in some of the treatments which have been recently announced. And I'm hopeful, let's put it that way, because these new treatments are really showing their benefit in people who come. Now, this will be hard to imagine. They come when they're at the mildest form of their dementia, or they haven't yet noticed any problems that are impacting their day-to-day, but they're so confident that they're going to get it because of the family history, and they're noticing decline, but it hasn't yet moved the Richter scale. And so people with pre-dementia and early dementia are getting the drug now.
So there are drugs.
There are drugs. And
Are we going to cure dementia in your lifetime,
I
my
think
lifetime?
you're going to have someone else in this seat other than me to answer that in a better fashion. I would say we're still a long way away from a cure, but it's just been a very hot area and continues to be a hot area for efforts in that. I mean, if you look at the number of trials that are out there on brain diseases related to dementia, it's an astonishing number of sort of research things that are happening around the world. So it may come, and let's you and I hope that it comes quickly.
Going to tap a little bit of wood there. Now you have one last area I want to just chat on as we wrap up, but you have the Kawartha Center.
Yeah.
And that is different than GAIN. What is the Kawartha Center and what are you guys doing there?
Okay. Well, as you can appreciate, when I was newly minted as a doctor and arriving on the coattails of my husband, who was transferred up here, I knew that it would be tricky for me to find a professional home because I work with a population that was new to think about, shall I say. At any rate, in the early days, I felt that I needed to see patients referred, but I didn't really have a place to do it, and I couldn't really afford to find an office. And one of the doctors in town actually loaned me his office one day a week, and we're still good friends. We still golf together. He was actually there last night. And he said, well, I'm not here one day a week if you want to use my office. And I remember in the 90s, I was using his office to try to see people. And at any rate, the call came out to work more in the dementia field, both in job opportunities in Pickering, in Whitby, that I went down one day a week. And I began to realize that dementia was a much bigger thing than I had been trained to deal with. You know, we're still learning, and we were taught about dementia, but we've learned a ton in the last 20, 30 years. And I invited a friend up who helped me to learn more about dementia. She was a neurologist. And she said, you know, you have a pretty select group of people with dementia. You should be doing clinical research. And through that intervention, or that person helping, I began to put myself out as somebody who would be interested in clinical research, and gradually built up the Kawartha Center. And it was designed, truthfully, around offering enough clinical research that it would pay for some staff to do that work. Right, okay. And in order to get into clinical research, I had to see people. So it helped me out, and the people I was seeing were people who wanted to be involved in the research. As I look back on it, it was it blossomed into something I never would have imagined. When I started, I hired a nurse and a secretary. And when I started clinical research, I added a part-time assessor onto the books. And we did very basic clinical research. And as the research became more and more and more complex, I just knew that they were going to subsidize the staff, and I kept hiring staff. So I grew from having not enough money to have an office to having 15 staff.
Wow.
And having 2 pharmacists. And we outgrew where I was, and so we ended up purchasing a building and then purchasing the other half of the building. And I never intended this. I just wanted to see patients, but it just wasn't easy to do out in the community. And so clinical research really gave me such a wonderful gift. It gave me the gift of exposure to all the research excellence around the world, because when you're in doing pharmaceutical research, they take you to meet with the other people who are developing the drugs. So you're right at the front line, learning about the drugs as they're being developed, learning about what their side effects are, learning how to infuse them, learning what the issues are, learning how often you need to do MRIs. So we were part of developing that, but we never knew the research is double blind and placebo controlled. So you would have people in front of you, they may or may not be on the drug. And it was a wonderful, wonderful life. So Kawartha Center now has offered this community access to international research trials in little old downtown Peterborough.
Yeah, I had no idea.
That, normally people would have to go from Halliburton to Sunnybrook to get the same kind of clinical trial, but they then came our way. And we became quite well known across Canada because people who live in rural Ontario don't mind driving in winter. They just don't want to drive to Toronto. Thank you very much.
But also you have an aging population in a small area.
Absolutely. And for once they had a place to go. If you were living in downtown Apsley or downtown Halliburton and you wanted to find out what was new and best in the world of research trials, you would come our way and be happy to drive the hour and a half. And for many centers, they say, really? They come an hour and a half? It's not perfect how we've been able to set it up because we're not close to the PET scanning that we needed to get.
Is there no PET scanning in this area?
No. So it was really tricky, and we had to, but they were reimbursed. The families became reimbursed as part of the clinical research trial. We negotiated that if these families had to go from Halliburton to Mississauga to get their PET scan, they needed to be reimbursed, and they were reimbursed for their mileage. And the most interesting part is that PET scans require a ligand, which is the radioactive substance, to arrive right at the right time. And so these people would leave like at 6 a.m. to get there at 10 a.m. to get their PET scan at 10:30. Sometimes the ligand didn't arrive on time and they would have to be going back home.
Wow.
And you would not believe how wonderful these families are. They would say, oh, well, we went and visited our cousin on the way, or we went and did a little shopping at Yorkdale, and then we came home. And to think of families in the throes of managing Alzheimer's disease at home in greater downtown Halliburton, traveling like that. I mean, these people have taught me so much.
Well, they're dedicated. Caregivers, dedicated family members, dedicated friends.
Educated and dedicated, willing. And back to the holistic part of geriatric care, I try to tell people that what geriatric patients and families show you in how they care. Despite this system that really gives them very little in the way of support, we have husbands learning how to cook, how to help their wives on with their undergarments, how to do things together, and they don't complain. And I have to say, it's sort of, I've told my kids, when you watch a family go through all the various stages of Alzheimer's disease and they manage it so amazingly well despite so little help. And it's sort of the embodiment of what love is. It's kind of the most sensitive and touching observations of how they roll with the punches in every circumstance. And
I think your film is this. I think your film is exactly what you said, the embodiment of love, both you for your patients and for the entire practice of geriatrics and dementia, and then to see those families and their love for, you know, the sacrifice in some ways they make, the great privilege in some ways, but the fact that like if you look at so many of the people you interviewed and showcased in the film, the person had changed. The person with the dementia had changed in some fundamental
progressed,
ways.
yes.
Yeah, and there was a loss, a sadness and a loss, but also a great hope.
Well, exactly. And one of the early learnings in dementia care with families is to remember that while the short-term memory may be gone, there's lots that's still working very well. And I think it was, Daryl, the fellow who took Bill Boyd out golfing, he was not trained, but he developed a relationship with this man and was taking him out of a secure unit of a long-term care facility 6 days a week.
Wow.
To go golfing in the summer and play pool in the winter and have lunch out. And when you talk to Daryl, which isn't in the film, about why, what was it that kept him going? Because he was only hired to keep the dad active 1 or 2 afternoons a week, but it grew to being 10 until 3, 6 days a week.
Wow.
He describes that his father died when he was very young, and he never knew his dad as an adult. He never got to know what it was like to go with your dad out golfing or shooting pool or taking him out to dinner. And his wife would say he was able to connect with Bill Boyd like a father figure. And Bill Boyd, by the way, had a great sense of humor, could tell a very wry joke. He's a good Scot. And he had a moral compass that also was helpful to Daryl.
Yeah.
So it
wasn't just one-sided,
No.
right? I'm hearing you say there is still a two-way street of a relationship.
and
It's
that's
just a
what
different relationship.
That's what we were trying to get in the film, that he says, best 6 years of my life, with a tear in his eye. And Gail Martin said, it was a joy. It was truly a joy to deal with her friend Gail.
Different. Like
Very
the relationship
different.
changed, but still an absolute joy.
I know.
Yeah.
And people have to understand that. We've got to allow families living with dementia to not feel stigmatized, sidelined, unwanted, unsupported.
Helpless.
And we have to, as a society, build communities around all our residents. They deserve it.
You still sound hopeful. I know the system is broken and I know there are calls to action, but you still sound hopeful.
Oh, I'm very hopeful. And I guess I'm hopeful because I keep on reflecting on the fact that we've got great daycares and great community colleges and great pension plans and great maternity benefits thanks to the boomers. And hello, we're here. Yeah. Let's hope that we do the same and make a great senior care system in our healthcare system in our community.
I like it. I have one last just sort of random question. Was it ever going to be anything other than medicine for you?
Oh, no. No. My husband and I often describe the difference in how we came to our final conclusions about what we would do. For me, pre-grade 1, I was saying I was going to be a doctor like my mother, and I used to count down the number of years of education I had because I knew I had primary school, secondary school, and I knew I would have 6 years of medicine and 4 years of specialist training. So I always added 10 years onto high school, and I would count down until I got there. And I never varied. And I remember when I got out the door of UWO as an internist, I thought, well, now I've done it. Now what do I do? It was like, oh my gosh, because all my life had been that. In contrast to many, and certainly my spouse, he had sampled all sorts of other opportunities. And he was the person who was juggling multiple options in his head. And
before the law struck
before
him,
law and his career in law. But our trajectories were so different. I never varied from medicine from a very young age. So they didn't call me Little Vera for nothing.
Is that what your nickname is?
Yeah, that was in the hospital. Because I would walk in the Princess Margaret Hospital as a 10-year-old, as a 12-year-old, as a 14-year-old. Like I owned the place. Like I knew every nook and cranny of the place because I spent weekends there, doing whatever while Mom was busy. And it was home. It was comfy. It was comfortable. And everybody knew me. And it was just a very comfortable existence. I thought everybody loved hospitals. I didn't realize that there were people in this world who didn't like them, because to me it was home. And at any rate,
I think we are very lucky that you were at home in a hospital from such a young age, because we're so lucky about sort of the career that you've had, that you've come to Peterborough and called it home for so long and done the work here. It's extraordinary. And I'm thrilled about your film, as you can tell. From the first time I viewed it on my little MacBook until last night, seeing it on that beautiful big screen, and everything in between. Thank you so much for spending some time with me, Dr. Ingram.
Well, thank you for having me here and hearing about my story and my future.
Thank you.